So I am very grateful to be asked to come and give an update about the state of the union in terms of Manitoba Air Ambulance. I would have to say I probably have the most interesting story to tell, and not because of innovations or great programs and whatnot. My update has a lot more to do with the destruction of a current program and what is going to come next. So the last time I was at this meeting, it was a lot smaller than it is now, so I'm really happy to see that it's grown. So I'll just give you a very, very quick overview of our current transport landscape. It's consumed by both private and public entities. I'm the medical director of Manitoba Life-Flight Air Ambulance, which is the critical care provider for fixed wing in the province. We also have partners in critical care air. STARS does the rotary wing component. And we have a variety of non-contracted carriers that mostly fly on turboprop planes in the north of the 53rd parallel, and deliver non-critical service to a lot of rural and remote communities. One of the issues, of course, is that they're dispatched centrally, but coordination between all the carriers is far from optimal. It's a bit of a mess, actually. So I became the medical director 10 years ago by accident. I was actually doing a favor for the current medical, or the past medical director, who had to do a favor, doing him a favor, and he needed some personal time, and 10 years later, somehow or another, I'm still here. So we always sort of hoped for a better future, but now it's one is being forced upon us. So my previous boss from Manitoba Health used to always say that if you want to make a really good omelet, you have to break a few eggs. And this is how things have kind of gone down in Manitoba. So we're presently in a state of disarray. The government, who was elected in 2016, imposed a freeze on new hires and aircraft heavy maintenance. So unlike many of you, our air transport platform for critical air fixed wing is entirely government owned and operated. So there has been a push on to privatize this service, which of course has had some drastic and horrifying consequences, which the politicians, of course, are completely unable to appreciate until disaster hits, because they're not engaged in patient care. They don't really understand that aeromedical transport is actually a very intimate marriage of medicine and aviation. And, unfortunately, you can't just take the foundation out from a program, which would be our aviation provider, and expect operations to carry on as normal, because they do not. So the deconstruction of our old paradigm is really forcing a birth of a new state. So now, I was mentioning to Dr. Talon before that one of the lessons that I really learned in this last year is that you, as a medical director and a patient advocate, you walk a very, very, very fine line between being political and being a good patient advocate. It's very difficult, and I've spent a good part of the last 6 months trying to keep my name out of the paper. But really, our tale is a tale of two conservative premiers. And I am not a politician, and I have no political leanings, but both of these gentlemen were involved in the same government 16 years ago that did some of the initial work around privatizing our service provider, which is Manitoba Government Air Services. And the efforts were aborted due to the medical advocacy, as well as a lot of other operational issues that they hadn't foreseen. The plans were dropped 16 years ago and were resurrected again when the new government was elected in 2016. So we have resurrected agendas and unfinished businesses. Political agendas have definitely been trumping patient safety and medical considerations, and this is going on into present day. So in 2017, there was an expression of interest that was put out to the community, to the private sector, to see who would be interested in taking over our aviation platform. Now, it wasn't just Manitoba Government Air Services that was going to be included in this. It was all of our basic air, so non-critical care providers that were included in this, because the thought was that there would be a significant savings in consolidating them. And I certainly don't argue that, because there would be. So the expression of interest involved by bundled fire suppression, general transport, and air ambulance all into an RFP. And the goal was to replace government air services, consolidate all air ambulance services, but they did not foresee, even in spite of the fact that they were warned that there would be considerable collateral damage around this. So I've heard many of you who preceded me up on this podium talk about your challenges in maintaining your population of fixed-wing pilots. So we have similar challenges now, which we didn't have before. The Life Flight program was actually seen as a destination job for many of the reasons that you have mentioned, and that is the ability to not be on a rolling rotation, to not be at a base distant from your home, to be able to sleep in your bed every night, and to have, because it's a government job, some very decent pension and benefits. So it's always been a very competitive destination job, right up there with the major air carriers. But when the expression of interest went out, that started to destabilize the program by pilots thinking about where it is that they could find better jobs and not have to worry about an inevitable loss of job. So we ended up losing a fair number. We ended up having a critical incident as a result of being put on King Airs and other prop planes that were not equipped for our service. We actually had a death as a result of it, and a CI. But even in spite of that, we did manage to hire a few extra pilots, and in 2018, the RFP was released in the middle of the summer out to the private sector, which drained our pilots again, because of course if you're going to lose your job, you're going to start looking elsewhere, which put us back on unsafe planes. And by unsafe, I mean not unsafe, uncertified, I mean unsafe because they're not configured for a critical care service. So what this resulted in was a physician shortage, because our critical care team comprises a nurse-physician model. So it resulted in a physician shortage and a lot of advocacy in terms of the hiring of pilots, and eventually spilled over to what we're experiencing in present time. As of April 1st, we only have 3 nurses to deliver 24/7 critical care to the province, which is horrific and devastating. However, because we have partners in critical care air at STARS, they have very generously offered up some of their teams to assist us crewing our plane until such a time as we can hire and restabilize. So with the election of this new government has come huge changes in care delivery all across the board. We're seeing closure of emergency rooms, we're seeing consolidation of surgical programs. I mean, we're definitely not the only program that's taken a hit. However, one of the good pieces of good news in the equation is that Shared Health Services, which is sort of a new entity under Manitoba Health, or under the previous WRHA, is now taking over all patient transport in Manitoba. So the plan is to have us all under one umbrella, which I think is going to be a very positive thing in terms of recruitment, retention, training, so all good things. The pilot vacancies so far have been filled. We currently have 10 pilots on our roster. We should have 12. But because we have really stood our ground as physicians, advocated for patients and safety, and refused to fly unless they hired, we have further training and recruitment that's ongoing. New nurses are being hired and trained. I already talked to you about STARS filling the gaps, and we are very, very, very grateful for that. So our goals are to stabilize critical care and fixed-wing program staffing, embrace new oversight in the short term, and consolidate all of air transport in the long term. So that is the short story about what's going on in Manitoba. Like I said, I would love to talk to you about innovations and programs and whatnot, but what we are purely focused on right now is survival. So anyone that has any ideas or feedback, I am completely open to hear your ideas, because I'm looking at this as, as embracing change. We cannot become what we want by remaining what we are. So everything happens for a reason, and I'm very much looking forward to being part of an integrated system, something that has a little bit more redundancy built into it, and actively looking at what our critical care delivery is going to look like. Who's going to be on the planes? Who's going to be on the, who's going to be on the ground? Who's going to be delivering critical care in Manitoba? So thank you very much, and I'm open to any questions offline, I'm sure, because John wants to get on with his programming. So.